this is a progressive disease. You're doing good now, but in order for this to remain this way, you do need to continue. You cannot lower your guard. You need to continue doing the things that you need to do, continue taking your medicine, continue follow-up, because that's what's going to tell you that you are in good track.
Welcome to Baptist Health Talk, a podcast on all things healthcare, powered by Baptist Health South Florida, your trusted source for healthcare prevention and wellness.
Hi, everyone. I'm your host, Johanna Gomez. Welcome back to a new episode of Baptist Health Talk, where we answer your most searched questions on trending topics. In today's episode, we're diving into the truth behind diabetes, a condition that's far more common and manageable than many realize. From early warning signs to everyday lifestyle changes that can make a difference. We're breaking down what you really need to know in honor of Diabetes Awareness Month. We are joined by Dr. Pascual DeSantis. He is the Chief of Endocrinology at Baptist Health, and Dr. Paolo Carvalho, Geriatric and Family Medicine Physician with Baptist Health Concierge Medicine. Thank you both for being here. It's great to have you here. This is a wonderful conversation to have. So many people have questions about diabetes. So let's start real simple. Dr. Carvalho, what is diabetes?
Well, thanks for having me.
Yeah.
And it's a pleasure to be here with Dr. DeSantis. Diabetes, like in simple terms, diabetes is just when you consistently test for high levels of blood sugar.
Okay.
So basically patients ask me like what diabetes is. Diabetes is a complex condition. Most of the times it's silent at the beginning, but it is basically defined as like elevated blood sugar levels.
Okay, so there's also type 1, type 2, and then there's pre-diabetes. Because there's so much confusion around, I have been around diabetes for a long time, unfortunately, because it's in my family history. And I still, to this day, I'm like, wait, which one is what? So let's break down type 1 and type 2 diabetes before we get into pre-diabetes.
Sure. Type 1 diabetes is mostly autoimmune. It's an autoimmune process where your body produces antibodies against the pancreatic cells that produce the insulin.
Okay.
And insulin is an important substance that breaks down sugar to make available for the cells to use as a source of energy. So being an autoimmune process, usually patients that have type 1 diabetes, that occurs at a very young age. And usually before age 25,
Wow.
like a childhood, so like a children, like usually they have signs already. And
They
then
have type 1 diabetes.
type 1 diabetes normally.
Right.
Yeah.
And they live with this for the rest of their life.
Yes.
You would like to?
No.
Yeah, okay.
Yeah, and these patients, usually they have a strong family history of type 1 diabetes as well, because it's strongly genetically connected. So there is a gene called HLA-DR34 that we test patients that have strong family history of type 1 diabetes. So this is one part of the screening that you do for patients that are asymptomatic.
Okay. Type 2 diabetes is something that you get as you get older in life. And I think sometimes you kind of blame yourself and your lifestyle for it, but sometimes that is also genetic as well.
That's correct. Type 2 diabetes is a multifactorial condition. Many things can be attributed to contribute and cause diabetes type 2. The type 2 is mostly related to the lifestyle. I would say like a sedentary lifestyle, lack of physical activity, diet rich in carbohydrates and sugars that can predispose patients to develop the diabetes type 2.
Yeah.
But there are other conditions as well, like insulin resistance. Your tissues can become sensitive, less sensitive to the insulin.
Right.
And that makes the blood sugar accumulate in the blood.
Right.
And but some medications as well. Some medications are known to increase blood sugar levels. So there are many conditions, but I would say less insulin sensitivity or insulin resistance associated with that pancreatic injury, either by a medication or a blunt trauma or even a tumor.
Right. And then there's also pre-diabetes, which it's kind of weird because it's like, okay, so I don't have it yet, but I have it. Explain that. Break it down for us.
Like the name says, pre-diabetes is like the process like to become
Almost
diabetic.
there.
Exactly, almost there. That's a signal of the body telling you that your body is struggling to metabolize that sugar. So either by decreased production or secretion of insulin, or by increased resistance or the peripheral sensitivity to the insulin.
So you broke down the age for type 1 diabetes, obviously very young, but at what age is there an age that you typically see patients being diagnosed with diabetes or pre-diabetes?
When patients, I see mostly adult patients. So type 2 diabetes is more common in young adult patients, like you can see after age 25, I would say. But it can happen at any age.
Okay.
Actually, it's increasing. Nowadays, we're having more and more children and adolescents developing type 2 diabetes.
Oh, that's very sad to hear.
Yes. And that's related to the lifestyle. They're becoming less active. They are more in the cell phones and they're not doing physical activity. They're eating junk food and they do not have a healthy diet. So it's more related to the lifestyle in that situation.
Dr. DeSantis, what is actually happening inside your body when you have diabetes?
Well, you can break it down first. What's happening for you to develop diabetes? And Dr. Carvalho already explained type 1 is quite straightforward because it's an autoimmune injury. Type 2 is a bit more difficult because you could consider like a two-hit hypothesis. You have a genetic predisposition and you need the proper lifestyle and environmental factors to let it flourish, okay? Once you develop it, what's going to happen is you're going to develop glucose toxicity towards the tissues that are going to predispose you long-term to develop complications. And that, of course, it's associated with all other comorbidities that the person may have.
Okay.
In type 2, for example, we see kind of like a compendium of conditions clustering together. Patients with diabetes, type 2, they're going to have more risk for hypertension. They're going to have more risk for high cholesterol. They're going to have an increased risk for cardiovascular disease and so on.
So it all kind of always is together, is what you're saying?
Not always, but in many occasions
Majority.
for type 2,
you
do see that clustering. Not so much for type 1. We see less of comorbidities, but the long-term effect of glucose toxicity does lead to macrovascular and microvascular complications.
Okay, so insulin resistance, when you hear that, could it just be that your body is just not resistant to it?
Well, insulin resistance, we have to be careful about that because
Why?
Insulin resistance, the most common cause that we know of insulin resistance is obesity and overweight. So anybody who is obese and overweight will have some degree of insulin resistance, okay? Now, in addition to that, you're going to have genetic predisposition. So people who are genetically predisposed to type 2 diabetes and they have a family history and
That's
so on.
me.
Right. Well, so those are people who are going to be more prone to allow that insulin resistance to flourish in the proper clinical context. Because it will not happen if you have a healthy lifestyle and you conduct your life over the years in a way that you look at the energy balance and so on.
Right.
But if not, which is the case of most people in our day and age, then it'll flourish.
So what are some of the early signs, and this is for any of you, whichever one you would like to know, that we should kind of be looking out for, or symptoms that people you see kind of just brush off?
Well, the early signs, most common is patients coming and say, "Doctor, I am having excessive urination, thirst." So they might have, I hurt myself and it's taking too long to heal. I feel fatigued. I feel very tired all the time. And it might be a blurry vision. So some signs, early signs that we can identify diabetes. And late signs would be maybe hyperpigmentation of skin folds, like in the neck, in the armpits. You have darkening of the skin and some texture changing, like a velvety, like a texture of the skin. That is called acanthosis nigricans. And this is something that we see more late like in diabetes.
Okay.
So some patients, they lived in like a very many years in diabetes, not knowing
That they have it.
Yeah, they have it. Yeah.
Right? Or that they're even like maybe
Yes.
pre-diabetic, living with it.
Yeah.
A lot of people think that type 2 diabetes, it's because you've been eating too much sugar, you've been hitting the cookies and the cupcakes too much. How much of that is true?
By the time somebody develops the symptoms of diabetes, they've had diabetes
They've had it for a while.
Yeah, so you need to have high glucose concentration to develop the polyuria, the polydips, the excessive urination, the excessive thirst, and so on.
Thank you for clearing that up because it's good to know.
But at the beginning, most people don't even know they have it. And they don't have any symptoms, and that's part of the problem.
Right.
So the sugar question, well, I'm not going to say sugars are not part of the problem. They are.
It is.
Okay. Highly refined sugars and so on. It's not the only factor. Obviously, it's a multifactorial thing. We live in a society that make us prone to sedentarism, lack of physical activity, and lack of time to cook. And so we usually have to resort to fast foods and ultra-processed foods, and which contains highly saturated fats in addition to highly refined sugars. So it's all in the mixture, okay? So it's not the only factor, but certainly it does play a role. I mean, the excessive amount of sugar that we eat.
We have seen so many documentaries, so much research done on diabetes, and a lot of them talk about also how culturally some people might be more prone to diabetes because of culturally the way you eat. Have you found that there is some truth to that?
There is, yeah.
There is.
There is some truth to that because, like I said before, it's an interplay between the genetic predisposition and the environmental factors, okay? And there are cultures that are more based on high intake of fast-acting carbohydrates. Let's say rice.
I was just going to say, and we're in South Florida,
correct.
Hispanic community, we eat rice a lot.
Yes, we do.
That's true. That's true.
I like your big smile and you're nodding. You're like, it is true. Dr. Carvalho
Right.
agrees.
Yeah, these are not simple things, pathophysiologically. And so we cannot just blame it on that. But does it play a role? Yes. Are there cultures that are more prone to eat? But let's say in America, right? Regardless of your background, ethnic background or whatnot, most people end up living similarly. Everybody's in a rush. Everybody's short of time. Everybody's trying to make the most of the time they have. And they, regardless of the culture, they end up eating fast foods and things like that. Well, that is culture, right? And that is not the proper way of eating.
But I will say, I'll just have a little bit of a pushback. You hear a lot of the Asian community, they eat a lot of rice just as well as we as Hispanics eat rice. Diabetes is not as common as it is for them than what it is for us. And I will let you handle those numbers because I know that a lot of people, like I am thinking right now, how many people actually are living with diabetes?
Well, according to the CDC in 2021, there were about 38 million Americans with diabetes type 2. Actually, diagnosed diabetes were 28 million approximately and 8 million undiagnosed. So you can imagine 1 in every 5 diabetic patients are walking out there, having diabetes and not knowing that they have diabetes.
Yeah, that's insane.
So it is, the number is estimated to increase in the next decade. So as far as prediabetes, 97 million Americans living with prediabetes. Wow. Out of this 97 million, 27 million are 65 years of age or older. Right. So basically, 48% of this geriatric population have prediabetes.
Have prediabetes.
Yes.
Okay, so what are some of the routine questions and that you are asking us to figure out if we could be pre-diabetic?
Yes, the routine questions from the patients to the doctor, doctors to the patients.
Doctors to patients.
Yep. Sometimes patients come to me and they don't tell me what can be a problem, an issue that can predispose them to have diabetes. Right. So it's my job to elicit those answers and ask the appropriate questions. And one of the questions is checking for the signs. Are you drinking more water than usual? You urinating more than usual? So this is the type of questions that I normally ask the patients. And I ask about family history, if there is any like a close relative, mother, father, siblings who have diabetes type 2 or type 1. Both are genetically linked, but it's a very strong family history for diabetes type 2. So I always ask about family history.
Yeah.
And also like about previous tests, if they have seen a doctor prior to seeing me, and if the doctor told them that the A1C or any of the lab work was like showing elevated blood sugar levels, I would be prone to ask those questions.
Okay. Dr. DeSantis, once someone has been diagnosed, what does that journey look like?
It depends on the type of diabetes, right?
Okay.
If we talk about type 2 diabetes, which is the most common one, it depends on the stage and the condition and the circumstance of diagnosis. So you can have somebody who was newly diagnosed during a hospital visit because of hyperglycemia, and you can have somebody who is diagnosed during a routine visit with the primary doc. Okay, so each case will deserve a different attention and different degree of intervention initially and follow-up. And depending on that, will establish what is the next step, okay? So let's say, which is, I think your question is, somebody who is diagnosed during a routine visit. They're going to an annual visit, and they were found to have diabetes. Usually, and if that person fits the phenotypical characteristics of a type 2 diabetic, so you have somebody who is overweight or obese, and they have hypertension, they have a family history of diabetes and so on. Okay, they have type 2 diabetes.
Okay.
That person will need, depending on the degree of uncontrolled diabetes, which is established by this parameter called the hemoglobin A1C, you kind of categorize that person. Usually, if they are asymptomatic, they're not going to have a severe form of diabetes. That person should first and foremost initiate radical lifestyle changes. And at the same time, they can be medicated.
Is that the first thing, lifestyle changes, that you would talk about?
It should be talked about. We probably don't talk about it enough, I think, because we go straight to the medicines, right? Because you want to fix the problem.
And rather, when you say medicine, I think automatically insulin. That's it.
No.
No? Okay.
Insulin is somebody who's...
no.
Not in my case. Maybe like...
Again, it depends on what was the circumstances of diagnosis. Where they diagnose in an urgent situation like a hospitalization.
Right, and that they need that or not.
Correct. And so usually that is the situation.
Everything
we go
is
straight
case by case. We might as well go ahead and say that to be safe.
Absolutely.
Everything is case by case.
So in the person who is typically diagnosed as an incidental finding during a routine visit, no, we're not gonna go straight to insulin. But in the person who is in the hospital with a pneumonia and they have sugars in the 400s, yes, that's somebody who goes straight to insulin, and then you can change the management later.
I have found that there has been so much growth in diabetes, right? Technology. We've got the glucose monitors that we see a lot. You've got insulin pumps. How has this changed the game for patients to actually stay on top of their diabetes?
Right. Okay, so the insulin pump systems have evolved significantly over the course of the last decade, and they're usually assigned more to type 1 diabetics. Not that the type 2s cannot use it. Yes, we have a few, not a few, but quite a few type 2s with long-term diabetes, with insulin insufficiency that will require an insulin pump. But most of the patients that are going to be on an insulin pump are going to be type 1s. And the algorithms that those systems have now embedded allow for a autocorrection of the insulin administration depending on the sensor data. So that has changed significantly the management, because has unburdened the patients a bit. Okay. Because now the pump system will take care of many of the things that they had to pay attention to before. Okay. The sensor, the continuous glucose monitors are not limited to type 1 diabetes on a pump. That was the old-fashioned way.
Right.
Now, we've seen a value of the use of the continuous glucose monitors, even for type 2s. And there are data even for pre-diabetics in terms of, now they're not approved for that, obviously, but in terms of research, they are very good tools to modify behaviors in patients.
I'm assuming that it's helped patients, it's also helped you physicians as well in being able to navigate and help. Is that true?
That is true. In my situation, sometimes patients, they like a type 2 diabetics, they request, can I have a continuous glucose monitoring? And that in some situations can create more anxiety than benefit for the patient, because they will be overly trying to correct the diet. And sometimes they, especially older patients, they can have some problems with not eating.
Yeah.
Afraid of that the sugar level is going to be above 100.
And then you have another issue there,
which is hypoglycemia.
Right.
And hypoglycemia is low blood sugar level, and that can be more catastrophic than the a little bit higher sugar level.
Yeah.
So especially for this patient population, 65 years of age and older.
How common and what is the rate of diabetes around the world? The numbers that you gave us of diabetes in the United States is staggering to hear. So what's going on in the rest of the world?
It is similar. As certain cultures are Latin America, you have higher prevalence than other places in Europeans. So there are some ethnical groups that are more predisposed. So here in US, we have the Alaskan, the island, the Pacific Islanders, Hawaiians, Native Americans, they all more predisposed than white Americans. Yeah.
Is it because of what we eat?
It's more genetically linked as well. But of course, the lifestyle, everybody's under the same basically lifestyle, like Dr. DeSantis mentioned. So we living in America, we basically have similar lifestyles. Of course, that's individual, each person have their own a routine and physical activities, but overall, we can say that.
Dr. DeSantis, how important is it to keep up with those follow-ups, the treatments, sticking to your plan when it comes to diabetes?
It's very important, right? It's a silent condition for the most part, and people don't feel bad necessarily, and that is leading to drop off or lack of follow-up and so on, especially men for some reason, right? And so it's important to overstate the importance of monitoring and continuing adequate follow-up, even when you are controlled, because it is unfortunate. And I'm talking about type 2 diabetes.
Yeah, because that's the most common.
It's a progressive disease. In other words, it does tend to get worse over time.
Yeah.
And so what works today may not work tomorrow. The most important intervention to slow down that progression is radical changes in the lifestyle, which unfortunately the majority of the population do not engage in, okay? And so people sometimes have a false sense of security if you see them one time and say, hey, you're doing good. Yeah. You can continue to follow up with your primary doctor. You don't need me for the moment. And then it's almost like...
Well, it happens. We're humans, okay?
I say, no, you do have to follow up.
We fall off track every now and then, you know? It happens.
You do have to follow, because I make it clear to them, this is a progressive disease. You're doing good now, but in order for this to remain this way, you do need to continue. You cannot lower your guard. You need to continue doing the things that you need to do, continue taking your medicine, continue follow up, because that's what's going to tell you that you are in good track.
But if you happen to fall off track, there is a bounce back. There's a glow up, as they say. Yes?
Of course. Yeah. We always leave the window, the door open for them to come back if that happens. And, we all have the same problem in life. We tend to fall off of everything. And then we have the opportunity to redeem ourselves. And we have tools to help them. We do have plenty of medications that we never had before, and we can help them with those. And of course, I always remind them, lifestyle changes, because the visit cannot be limited to medications. We always have to remind them, lifestyle changes need to happen.
Well, a lot of people talk about that. like the lifestyle changes that you can actually reverse your diabetes. Is that so?
I wouldn't say reverse your diabetes. The word is more remission, because reversal implies cure.
Yeah.
I prefer not to talk about that. I prefer to talk about a remission. You can have your diabetes go back into remission. Excuse me, but it will always be there. And if you fall off again, it'll come back. It's not like you cured it. Okay.
Just complementing that, it's just also like the control. The well-controlled patients, they have different ranges of this test that we normally check. The hemoglobin A1C, for example. For each age, we have different controls and like recommendations. For instance, like geriatric patients, the good control is between like a 6 and 7, the hemoglobin A1C. For a younger patient, I would probably keep them in a lower level. Dr. DeSantis can correct me if like he does something different, but it is just for a matter of safety for the patients, depending on that like age that they are. So as like you progress in life, the treatment might change a little bit. The medications might be indicated in a different way. So that's why it's so important to keep that follow-up with the physicians.
You mentioned earlier also how this really can affect other stuff like your vision, your kidneys, other parts of your body. Can you go ahead and emphasize on really how much your blood sugar being out of whack in your body just can affect everything?
Yeah, definitely. The blood sugar, like when you have an elevated blood sugar, that can create an oxidative process in the cells. So the sugar is within the blood vessel, and the blood vessel is the first one to be damaged. So usually the blood vessels will have like a different size of blood vessel, and the smallest blood vessel is called arterioles, and those are the first affected. Okay. They are present in the organs such as kidney, brain, heart. Even the nerves, they get nourishment and nutrients and oxygen through these arterioles. So once they are damaged by the sugar, then you start having kidney disease, you start having like a heart problems, you can have like a stroke, you can have neuropathy, which is a common condition that diabetic patients, especially the uncontrolled patients, develop. Yeah. So we need to pay attention to not allow the disease to progress to that level.
There's so many myths online. We're going to start off with one. I can't eat any carbs. Yes or no? Whichever one of you would like to take that one.
I would say that's not true. I mean, you can eat good carbs, excuse me, and a limited amount of carbs. And you want to stay away from the highly refined flours and highly refined sugars. But you want to stay away from a large portion of carbohydrates, but carbs have a role
and they're great. I will say,
I love them.
Love them too.
Right. We tend to love them too much, but no. It's not a matter of elimination. It's just that portion control. And exercise, good quality food. I mean, stay away from that.
Can't emphasize that enough.
Yes.
Biggest misconception you have heard from patients?
That diabetics, like a medication, once you are on a medication, for instance, insulin, type 2 diabetic patient that need to use insulin for a short period, they are very afraid because they keep saying, well, once I get into insulin, I will never come out of it. Right. And that is a misconception.
Beyond the medication, we've been talking about it so much. Stress, sleep, exercise all have a big play on it. But when I hear stress, I think, how does that affect you're saying, yes, it can affect you, the stress.
It does. So stress can affect, I think, the blood sugars in two ways. Okay, one way is directly. So we know acute physical stress throws up blood sugars even in non-diabetics. So we see that in people with trauma, severe infection, sepsis, car accident, things like that, surgery. All of those are acute physical stresses that are going to elevate the blood sugars. Emotional stress, which is the one I think you're referring to, can affect the blood sugars directly to some extent, but to a much lesser degree to what I just explained, okay? But I think emotional stress affects the blood sugar mostly taking the focus away from the necessary changes you have to make. Because if you're stressed and focused on something, financial, you have a family member who needs to be taken care of or whatever, that's going to shift your focus away from the things you need to be focused on to really improve your glycemic control.
Yeah.
And I think that's a more important way how stress affects the body, although it does affect it directly, no question.
And by the way, I think sometimes when people are stressed and you're emotional about something, there's also emotional eating that goes into that, which there you go, you have now a problem.
Right. And you mentioned sleep as well. So once you stress, you sleep less. And the night sleep is very important because that is a substance that's released by adrenal glands called cortisol. And that cortisol, like when it's kind of dysregulated in your blood, can elevate the blood sugar. So there is something very important, like to have a nice lifestyle and sleep well.
Yeah, we all need a little bit more of that as well.
Have some vacation.
And a vacation time. Yeah, no stress. If a patient is nervous to bring up a diabetes risk in their lifestyle, what would you say is a great way to just have an icebreaker and kind of start the conversation?
I think it was a joke. A joke always comes, yes. So you making the patient feel comfortable and that they can trust you, that you're there, have their best interest at heart. Yeah. I think that's very important to start a conversation. I would never go straight on to the topic if I feel that the patient has some sensitive issues with certain conditions, and diabetes is one of them.
Yeah.
So I try to first kind of scan the patient and see how comfortable they are in discussing diabetes.
Anyone who is listening right now is probably could be feeling, I should say, a little overwhelmed, maybe a little nervous about maybe being diagnosed or just newly diagnosed. What advice do you have for them? This is to both of you as they get ready to start this journey.
Well, first, you're not alone.
Yeah.
You have a lot of people that you can count on. And we have a lot of resources. The first thing you have to do is to go to your doctor. Right? If you are if you belong to one of the risk factor categories, age over 50, you have hypertension, if you have a family member, first-degree relative, if you have a woman who had gestational diabetes, all of that would put you in a category of risk. Go to your primary doctor, have them check you, do the screening and so on. Once you are diagnosed, no reason, it's not the end of the world. We have tools available to us that we never had before, like I said before, that can help. And it's a matter of taking charge. Yeah. Taking charge of your life and introduce the necessary changes that are needed, and then follow up. Go to your doctor and discuss it with them. It's not the end of the world. We'll help you.
Yeah, I make Dr. DeSantis my words. It's just the same. It's just having the judicious a follow-up. Once you find out or we diagnose a patient with diabetes or pre-diabetes, we have many different resources. It's very important. I didn't mention before, but is when patients have that diagnosis of diabetes, there is some recommendations of extra screenings, yearly screenings. One of them is a renal disease, and the other one is a peripheral neuropathy and diabetic foot. So very often I send my patients to specialists, and sometimes I even need to send the patients to the endocrinologist because they have multiple endocrinopathies. So and patients don't follow up,
right?
And they don't do the screening, the recommended screening, and that is an issue for us because we trying to see the patient as a whole and not only treating the sugar levels.
I'm not sure exactly if you can answer this perfectly, but I am curious because you said over the age of 50, you said kids are being diagnosed with diabetes. Mm-hmm. As a parent, what do I have to look out for? Signs? What should I be aware of with my child? I don't think a lot of people think of kids that don't have family history, right? Type 1 diabetes, you think of kids, but what should I be aware of?
It depends on the family history. So if you have a family history of type 1 diabetes, the child...
but if you have type 2?
Right. If you have a family history of type 2 diabetes, your child will be at risk. Before the 90s, we would think that person would be at risk later on.
Right.
With the obesity epidemic we have in children, unfortunately, then has brought up diabetes. There is a term
to the forefront.
Yeah, there's a term called diabesity, which obviously links the two together. So the majority of those kids that are unfortunately now diagnosed with type 2 diabetes are also obese. So of course, so essentially, the kids need to play sports. Kids need to stay away from tablets and devices. Kids need to eat healthy, stay away from highly refined sugars and so on. I mean, this is basic concept, right? If your kid is engaging in all those things that should not be, well, then they need to be tested. And if they are overweight or obese, they need to be tested.
Yeah, something to look out for.
I think a simple way, like Dr. DeSantis mentioned, is like obesity. If your child is gaining weight and now becoming overweight and obese, then we should have to start thinking about it.
Got to start having that conversation.
Yeah.
Speaking of conversations, this was wonderful. Thank you both so much for your time, for your insight, for sharing all the information you have with us and with our audience members. We truly appreciate it. And remember, to our viewers, be sure to hit that subscribe button on our channel right here to keep up with the latest health and wellness information and tips from our experts. Thank you so much for watching, and be safe.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Baptist Health Talk is brought to you by Baptist Health, the warmer side of care.